All right, guys, we're getting into the last few disorders of this section. So this particular video is going to be over acute pancreatitis, but we have for biliary disorders, we have acute pancreatitis, chronic pancreatitis, and then we have the gallbladder disorders or coli problems, as I call them. So these are kind of an extension of like lower GI or other GI issues, but they kind of are in their own category, which is why I have them in their own PowerPoint. So let's talk about acute pancreatitis. This is something you'll definitely want to be familiar with. There's a lot of patients that come into the hospital with this, and there's also a lot of like NCLEX-like questions. There's a lot of stuff that can go wrong with acute pancreatitis. So it's definitely a topic that you want to be familiar with. Any topic where it's like a disease where like things can go wrong, the nurse needs to take action. You just want to focus on those. I'm not saying it's the only one. Sometimes NCLEX gets random and does some other, stuff that's not very common, but we try to stick with things we're going to see often. And this is definitely something that if you work in any sort of medical unit, even if you do things like work in an ICU or work on any sort of cardiac unit, you might see patients that have this as a problem. So acute pancreatitis is, as the name suggests, it is a acute inflammation of the pancreas. And what happens with acute pancreatitis is that you have to go back to what are the functions of the pancreas. Now, most people, the first thing they say is like, oh, insulin. And yes, that's true. The pancreas does help us to secrete insulin. But the other thing that it does is it helps to give enzymes. It deposits enzymes into the digestive tract in order to help break down food. And so what happens during acute pancreatitis is that the pancreas gets pissed off, inflamed, and it just starts spilling out all those enzymes that are meant to digest. Now, in the digestive tract, those enzymes are very helpful and needed. But what happens in acute pancreatitis is they start to spill out other places, and actually they start to auto digest or eat the pancreas itself. So in other words, it's starting to like literally like self digest itself. So it starts gnawing at the pancreas itself. It can also spread to nearby tissues and cause lots of issues to places like the lungs. So it can lead to a lot of problems because I always think of them like little Pac-Man that are going around and chomping on everything. Now, there's a variety of causes for them, but in the United States, per your textbook, the most common cause of acute pancreatitis in men is going to be chronic alcohol use or long-term alcohol use, and the most common cause in women is going to be gallbladder disease. Now, there's, of course, lots of other reasons that it can happen, so don't necessarily, you see an acute pancreatitis patient, you shouldn't say like, hey, they must be a drinker. We don't know, but just kind of keep in mind that those are some common reasons why people get them. Other causes would be, drug reactions, high triglycerides can lead to it, or pancreatic cancer. So this patient is one of the main symptoms and one of the main priorities for this patient is going to be pain management. So this person is going to feel pain that is in the left upper quadrant or mid-epigastric area. And that's going to be because of course, where the pancreas is located. But their pain is going to be a lot worse when they're eating because you have to think about like, okay, if I have a pancreas problem where my pancreas is spilling too many digestive enzymes, what tells it to make more enzymes? It's when we eat. So I usually just tell the story about the guy that one of my patients had that was having really bad really bad pain. And so we decided to drink. And he's like, man, it was just so strange. He's like, I drank like a fifth of whiskey. And I was like, man, it's not getting, well, maybe I think he started with beer. I want to say he drank some beer and he was like, oh man, it's not getting better. And he's like, and that's when I realized I needed to be drinking whiskey. And so then he tried whiskey and of course it just made things worse. And he went in and he's like, I don't know why they're calling me an alcoholic. I was just trying to get rid of the pain. And that's the thing is that sometimes this pain is so bad and you keep thinking if you put something in that it's going to make it better, but it just makes it infinitely worse. The pain is going to also be sudden. It can radiate to the back, and usually they describe it as like a severe, deep, or piercing pain. They also commonly have nausea, vomiting as a symptom. Their bowel sounds can be decreased or absent because of the inflammatory process. They can have a low-grade fever. And we also want to look for respiratory symptoms like shortness of breath or dyspnea. And then any sort of abnormal lung sounds like crackles. Some priority assessments we want to do. This patient can have a lot of instability, like hemodynamic instability. So I want to check their heart rate and their blood pressure. I'm going to be looking for shock. And remember, with shock, your heart rate goes up, blood pressure goes down. We're going to be assessing for those GI symptoms like nausea, vomiting, and seeing what makes it better or worse, assessing for bowel sounds, looking for those systemic signs of infection, assessing pain. There's also two signs that are really commonly connected with acute pancreatitis. They can be caused by other things, but they're most commonly associated, especially NCLEX-wise, with acute pancreatitis. And one's called the Gray-Turner sign, and one is called the Cullen sign. And both of these are like a bruising or a bluish color. And the Gray-Turner sign is a flank discoloration. And what you want to remember with your flank is your back, like where your kidneys are. And so you want to be looking, you want to be looking there for that discoloration. And I always remember Gray-Turner's because you have to turn to their back to see it. And then Cullen's sign, I think of like a C, because I always think of this picture. I think of it almost looks like a C around the umbilical cord. Around the umbilicus. And so it's kind of a C or a circle, or you could think C for circle around the umbilicus. Or the belly button. We also want to look for signs of complications like peritonitis. They can get systemic inflammation and infection. We're going to talk a lot. There's a lot of complications with this. And then the other complication they're at risk for is what's known as, and I'll talk more about this on the next slide, but we want to assess their respiratory status and do a really thorough respiratory assessment because they're really high risk for what's known as ARDS or acute respiratory distress syndrome. I can talk. So acute pancreatitis is better if their pain and symptoms are improving, if there's signs that they're getting adequate nutritional intake or tolerating their parenteral feeding, because we want to make sure, sometimes this can stick around for a while. So we end up having to do alternatives. We'll talk about those when we get to treatments. We want them to have decreased or absence of fever or any signs of inflammation, and of course, no complications. If their pain and symptoms are increasing, if there's signs of poor or inadequate nutrition, increasing worsening fever, signs of inflammation, we're going to be concerned about them having, getting complications or having long-term complications, of course, systemic complications too. The specific signs or complications we usually talk about infectious kind of complications where they can have systemic infection like SIRS or sepsis. They can get what's called a pseudocyst, which we'll talk about more on the next slide. But like a pocket of nastiness pretty much can form on the outside. It can burst. So yes, it can definitely cause problems. These patients, it's really not well understood why, but they can kind of sequester or hold on to calcium within the pancreas. And it leads you to have in your blood less calcium, which can lead to tetany, dysrhythmias, things like that, which will always be concerning. And then they can also go into what's called ARDS, and I'm going to talk about ARDS for a little bit. This is what we call a whited out chest x-ray. Like normally the lungs should be black because there's air moving, but there's all this junk. And what happens is that because of where the pancreas is located and the enzymes and stuff can spill into the lymphatic system that's connected to the lungs are very permeable where they let stuff in sometimes that maybe shouldn't get in. They're very prone to inflammation or fluid shifts. Remember how I always talk about how if you're going to get fluid shifts somewhere, usually the first place is going to be the lungs. So it's really common to get what's called ARDS, which is an inflammation of the lungs where to the point where it gets so full of junk that oxygen can't get in. So no matter how much oxygen we give these patients, their oxygen levels can't come up. And so we end up having to do all these crazy strategies. You'll learn about it in, and when I say crazy, it's not that crazy, but intense strategies to get them oxygenated and save their life. It's very high mortality rate. So let's talk about these other complications. So they can collect excess pancreatic enzymes in these little cysts. If they become infected, they can get an abscess. They can end up with systemic infection. This can burst. I talked about how they can spread into the bloodstream or the rest of the body, ARDS. We worry about sepsis and things like that, which is a bloodstream infection. Again, that can also travel to the lungs through the lymphatic system. And then calcium gets deposited in the pancreas. They can have that low calcium, which can lead, again, dysrhythmias and a lot of issues. But yeah, the pancreas can definitely, with inflammation, everything goes haywire. Some labs and diagnostics that we'll want to look at, we'll want to check their pancreatic enzymes. Normal is going to, for amylase, is going to be less than 120, and for lipase, it's going to be less than 160. So both these pancreatic enzymes can be looked at, but lipase is definitely more specific to pancreatitis, whereas amylase can be elevated for a lot of other reasons. So normally we're going to be looking more at that lipase versus that amylase. Also liver function testing, checking an AST, ALT. Normal, again, is less than 36-ish. You know, they're a little different in their numbers, but around then there's what we're looking at. Because again, you can see here with the pancreas, it's connected to the gallbladder. And if the gallbladder, the liver aren't working, stones are building up, it can lead to issues. We're going to check for complications too. We'll look at a calcium level. Normal's 9 to 10.5. We would expect it to be low because the pancreas can sequester that calcium. We'll also check a glucose. Usually during acute pancreatitis, it's going to be elevated because of irritation, inflammation, and stress in the body increases your blood glucose. Patients with acute pancreatitis are not high risk for being diabetes necessarily, or getting diabetes. We talk about that more with chronic, but we do want to keep an eye on their glucose, because if the body's fighting inflammation, you know, we want to make sure that the best way that inflammation, infection, other stuff can heal is if those glucose levels are under control. And then an ABG, and then we have to think about, what complication would this help with? And if you said ARDS, you are correct. We wanted to keep a close eye on the ABG to see what's going on when it comes to their, we call it respiratory status, oxygenation, because what we look at, you don't have to know this in depth, like for this exam, but definitely we'll want to note for complex is that we have what's called refractory hypoxemia. And what that means is, again, is like no matter how much oxygen I give this patient, their O2 levels are still going to be low. So they could be on 100%, tons of flow, and still have like barely any oxygen sats. Like some of these patients with ARDS patients, I've seen them have a low, like a SAT in the 70s, and that's good for them. Like that's the best we can do for them. So we're going to check that and look for any sort of respiratory acidosis, that kind of stuff. And then we want to find the problem, of course, visualize the gallbladder to see if there's stones, because again, depending on the cause of the pancreatitis, we need to get to the bottom of it. If there's an obstruction, we need to relieve that obstruction. All right, so let's do a practice question. It says, for each of the following prescriptions, indicate whether it is indicated, contraindicated, or unnecessary. So the first one, and this should say for acute pancreatitis. The first one says diet prescription NPO. So this is a patient we talked about that anytime I stimulate or put food into them, drinks in them, whatever it might be, that they secrete more pancreatic enzymes, which makes things worse. So it seems to make sense to me that we would want them. So it's good to have them NPO. The next one is chest x-ray daily. So I know we talked about having respiratory complications. I just don't know if we have to check an x-ray every day versus if a problem came up or if they started having abnormal lung sounds or changes to the respiratory status, we might want to check one. So I'm going to say unnecessary. It's not going to hurt them to get one, but I don't know that it's necessary that we check one daily. D5 half NS, 150 milliliters per hour continuous. This is like IV fluids. So this patient is going to be high risk for being dehydrated because they can't probably take anything orally. They may have been nauseous and vomiting. So this seems like something that would be appropriate. And if you're wondering about that D5, because you might be saying like, ooh, didn't you say like their blood sugar can get increased? D5 half NS is not a ton of sugar. And this is considered, this is a fluid that we use pretty regularly for patients. So if you're looking deep into it, or you're like, ooh, 150, that's a little fast. Like I'm just really trying to more so get here for helping you understand that IV fluids are appropriate for a patient with acute pancreatitis. The next one, ibuprofen, 800 milligrams PO, PRN for pain. So they're going to have pain. But the thing with the patients with acute pancreatitis is they have such severe pain that ibuprofen is not going to do it, and on top of that, this is PO. So it's going to put them at increased risk for, having issues with more pancreatic enzymes spilling. So this is going to be contraindicated. TPN 75 milliliters per hour continuous. So this patient, like I mentioned, has some nutritional deficits, and because they can't take anything by mouth, it is possible, and I would think it would be appropriate for them to have some sort of parenteral nutrition. So I'm going to say yes, indicated. Ondansetron, 4 milligrams IV push for nausea. It's a good way to practice to see if you know your meds that we've talked about. So ondansetron is also known as Zofran, and so which is a antiemetic. So we have to think, one, are they going to be nauseous? And two, is this an appropriate route for the medicine, etc. So it's IV push. So yay, we like IV push. And then, yeah, that like we talked about before, this patient can be nauseous and vomiting, have vomiting. So this is a appropriate order. All right. CBC and BMP daily. So a CBC, lets us know what their white blood cell count is. It lets us know what their hemoglobin is, their platelets, and then a BMP tells us about electrolytes and kidney function. So all of these can be affected with pancreatitis. So I would think it's indicated. O2 therapy, PRN to keep SpO2 above 95. So this is a good time to ask yourself, does this person have a potential oxygenation issue? And the answer is yes. Remember, they possibly could have those the respiratory changes because of the movement of the pancreatic enzymes to the lungs and things like that, and just the systemic inflammation that can occur as a result of pancreatitis. And so this does seem like an appropriate order. Insulin drip continuous IV. So I did say that they could be hyperglycemic, but an insulin drip is usually reserved for people that have like really severe hyperglycemia, like DKA, stuff like this. So I'm going to say this one is unnecessary. I'm sorry, I'm dying for some reason. It's like, hey, you're almost done your video, so here, I'm going to make you cough where you can't talk anymore. So to sum that up, overall, what we're going to do for this patient is we give them IV fluids. We might also do calcium replacement. If their calcium is low, replace any other electrolytes. If they're in shock where they have that high heart rate, low blood pressure, we might give them things like albumin, which helps to get fluid where it's supposed to be. They're going to receive things like proton pump inhibitors, antacids to help, because we want things to not be irritating, especially in their GI tract. And then this patient's going to either get what's called post-pyloric tube feeding. And that's that thing I talked about with the Dobhoff, where we put that tube all the way into the duodenum where it's feeding them, but it's going to be past the point where the enzymes are going to be secreted. So in other words, we're pretty much bypassing the system. Like, it's almost, think of it like a surveillance. Like the pancreas has a surveillance system in the GI tract at a certain point that when it senses presence of food, it secretes enzymes. Well, we're bypassing that, going past that, so we can still give nutrition without the pancreatic enzymes being secreted. Either that, or they can get TPN parenteral nutrition. Just depends, doctor preference and the patient, how they're doing. Usually they're going to be otherwise NPO and have an NG tube. Sometimes what these patients have is in one nose, they'll have an NG tube that's sucking stuff out of their stomach, decompressing, and then the other nose, they might have a post-pyloric tube. So don't think that just because someone has a feeding tube that they can't have a regular NG tube as well. Sometimes patients have both. It's uncomfortable, but sometimes necessary. Wake up. It just depends on how the patient is doing and what their needs are, etc. I won't say that I've seen a ton of patients that have both of those, but there are times that they need an NG tube and we also need to feed them. So it just kind of depends. Surg, and we only use like regular NG tubes for decompression. It has to be a thick tube. Those Dobhoffs are too thin, so we can't use a tube to decompress and feed them, just if you're wondering. Surgery is sometimes needed, especially if they end up with a complication, the pseudocyst, systemic infection, peritonitis, that kind of stuff. We talked about supporting their oxygenation as needed. It's not to say that every patient with pancreatitis is going to have a lung issue. We need to just watch it closely. Sometimes they're also hurting so bad it's hard to take deep breaths, so they'll also be at risk for respiratory complications. We give them things like antispasmodics. You don't have to know those names or meds in depth. Pain management, and we talked about before, they're going to be in a lot of pain, and pain is a huge priority for these patients. But what we usually give them is IV opioids because their pain is that high, and then also we don't want to do anything to stimulate their bowels that way. And then antiemetics as well, like ondansetron, Zofran, or Phenergan. As the nurse, I'm going to teach them to flex their trunk, draw their knees to their abdomen, or side lying with the head of bed elevated, because we want that head of bed elevated to help with the respiratory stuff. But sometimes that flexion in the knees can make a big difference. And then the side lying sometimes with that flexion can help a lot. I want to improve their comfort, especially if they're nauseous, vomiting, good oral care, monitor that respiratory status closely. They may need ECG monitoring, especially with that hypocalcemia, keeping a close eye on that, monitor for tetany. The two signs of tetany is, you poke their cheek, what do you call it? You poke their cheek and they have kind of the spasms in their cheek. That's known as Chvostek sign. And then also if you do their blood pressure and their two fingers go together, it's called a carpal spasm. That's what's known as the Trousseau sign. Education-wise, if alcohol or smoking is a behavior they regularly engage in, I would encourage them to stop that or change those habits. And then after resolution of their acute pancreatitis, usually a low-fat diet, and carbohydrates are less stimulating to the pancreas. So that's usually where we start. So especially like when I'm starting them back on a diet after they're getting better, a higher carb diet can actually help because it's less irritating to the pancreas. I think that's it. I'll see you next for chronic pancreatitis, if the Zoom will end.